Welcome to Vet Watch at DVM 360. I'm your host, Christopher Lee. We're talking today about ophthalmology. I'm really excited today to introduce Dr. Jennifer Sheahan. She has a major in biology and criminology in 2003 through UC Irvine, then went to Oklahoma State University, had a surgical internship at Ohio State University, and a residency in comparative ophthalmology at the Animal Eye Care. She focuses on dry eye disorders, retinal diseases, and in her free time, loves photography, running, traveling, and spending time with family. So welcome, Dr. Sheahan.
Hi, thanks for having me today.
So it's great to see you. I'm really excited to have you on the show today. And today we're talking about a lot of basic tips and tricks. And one of the ones that we had talked about just prior to starting filming was tonometry. And kind of giving an overview on why that's important and maybe why, a veterinarian may not be suspecting it on a basic eye case and why they should be running that test.
Sure. So tonometry is quite important to make sure you are in normal eyeball pressure range. It helps you rule in or rule out certain things that might be on your differential list. Okay. So when you have a dog that comes in with a slightly hyperemic eye, that could be simple as allergies, or it could be simple as you're having early glaucoma, and that's one of the early signs. So a pressure test could be life or death for the eye, and very simple to be like, oh, the pressures are normal and it is not glaucoma. Change trajectory. It could just be allergies and, Pat-a-day eye drops, topical NSAIDs versus, oh my gosh, the pressures are like 35. Trajectory, try to focus on glaucoma, primary versus secondary. So eyeball pressures are very important because it's very, very different on where it leads you on your, workup and diagnosis. There's a couple machines that are out there that are also all great. We have all sorts in our clinic just to, double check eye pressures in case there's ever suspicion that is it the machine, is it the dog, that sort of thing. So it's important. Tonometry should actually be done probably on pretty much on every eyeball case that comes in through the door, just as a baseline. I think it's important. Even if a dog comes in and it has dry eye, guess what? That doesn't mean it can't have glaucoma too. Okay. You're like, oh, it looks like dry eye. It has this goopy discharge. What's to say it doesn't also have glaucoma? You can have a hemorrhoid and you can have, testicular cancer at the same time. They're not related. So I think it's very important just because it's like, I know this is dry eye. That doesn't mean you shouldn't check pressures. So every eye case, it's not wrong. What is worse? There's more harm in not checking and not knowing versus, what's the worst case is you checked and you didn't find anything wrong, right? So I think that's important to just cover your bases.
Great advice. So even those that come in, it looks like a simple eye infection, in addition to the stain, make sure that we're adding on those tonometry readings as well. What is the normal range for tonometry?
So I would say it's like less than 25, but you always want to read every case, right? So it's not just, I often have these kinds of cases where, we get consults on the phone and they're like, oh, the tears are normal. And I was like, oh, well, your pictures don't say that. So we should tell me more, what is normal tears? They're like, it's not dry eye. The tears are normal. And I was like, well, what is normal? They're like, well, they're like 14, 15. And I said, well, you can have early dry eye and it's starting to show the signs that just because it's like 15 or 14, but it looks like dry eye, doesn't mean it's not dry eye, right? So what is it going to have to take for you to diagnose it as dry eye? Is it going to be a 5 with a hole in its eye? So I said, you have to read the patient, it's not always just by numbers, right? So if it looks like dry eye and the tears are 15, 15 and higher is normal. That's not always true. You want to think bigger picture and make sure it's not like, oh, well, we saw them 3 weeks later and there's a hole in the eye and the tears are 8. Yes, because that was dry eye. So you want to, take a step back, see what makes sense, do the eye tests, and treat for what you see. So, in relation to the eye pressures, you're like less than 25 is normal traditionally, but if you have a pressure of 5, that's also too low. You can also detach your retina from being too low on eye pressures. 25 is not necessarily normal, because if it's like, ooh, his eye looks a little bulgy, maybe he's spiking in the middle of the night. Traditionally, eye pressures spike highest at like 3, 4 in the morning based on diurnal studies. So you're catching him at his lowest, time period. So he might be actually like 35, 40 in the middle of the night, right? So you got to read the patient. So you can also have too low of pressure. So if pressures are 5 and it's technically less than 25, it's uveitis. That is abnormal. So you'd want to treat that. So you want to look in, see if you see any flare. Is it floaty bits and cloudy? Flare means proteins or cells floating through the eye. It's kind of cloudy. You see that in cats with uveitis and dogs with uveitis. And then, oh my gosh, his eye's kind of stretched. It's a little bulgy. But his pressures are 25. It's kind of weird. He could be, you could be missing a spike that's happening throughout. So less than 25, but what are my favorite pressures? My favorite pressures, 11, 12, 13, 14, 15, 16, 17, but you got to look at the overall picture. Nothing is cookie cutter in medicine.
When's too low? Is it 5 and below, 10 and below?
It's every patient's different, right? So like 9 and lower is kind of low. But, as we get older, you have these like 19-year-old Chihuahuas and their pressures are like low, or 19-year-old poodles. So just like in people, we make less muscle, we make less bone, we kind of shrink as we get older. They sometimes make less eye fluid. And so you get some of these like super old dogs, and I've seen and they just have like hypotony as they get really, really old. So you got to read the patient, but like obviously 7 is pretty low, 5's pretty low, 8's pretty low. You got to look at the patient. Is he just really old? Does he have inflammation in the eye? Did he have a procedure done to this eye? Did he have chronic uveitis and now his ciliary bodies, which is the faucet in your eyes, just shutting down over time? So, single digits are kind of low. So you should be like, what's going on here? And then you should always, even though they come in for the big bulgy eye, you should always check the normal eye, right? So you always want to check the eye, be like, what is baseline? Oh, this normal looking eye is writing at teens, like this weird eye is like low or too high. So it's kind of important that you always see what, this is your normal control. So always check the other eye, even though the client only came in with the concern of the one eye.
Good tips. And with regard to tonometry, I know I talked to some technicians and assistants that they hate doing it. And a lot of times they're sitting there and they're just poking this dog until it's just on its last nerve. And they're trying to get a certain number of readings. And so do you have any tips or tricks on that? Maybe walk us through the different types of tonometers and how to use them.
Sure. So whenever you position for a dog or a cat, you want to make sure that there's no pressure on the neck, don't push on the the neck whenever you're checking pressure. So we usually do like a chin rest position. Okay. So that is one where the holding is quite important. And whenever you do the tonometer, our favorite tonometer is the tonovet. And the tonovet is just quick. You don't have to use proparacaine. Literally, I can walk up to myself right now and do it, and it's you don't even feel it. And it averages after 5 beeps to give you a reading. Okay, so there's a little probe and it bounces out, and it's how quickly the probe, bounces back to kind of calculate and calibrate to see what your eye pressure is. Okay. And then the other one that's a little less expensive, more affordable for GPs is the tonal pen. But we have both, an oldie but a goodie. Okay. Because sometimes I'm like, oh my gosh, they've done papers and they've shown that the tonal vet reads just a little bit higher than the tonal pen, but they're both pretty, reasonable within each other. So if ever I'm like, I don't know about the tonal vet, go grab my pen. That's a completely different, mechanism of how it calculates on reading pressures. So how hard you have to push on the eye calculates based on how much the foot plate has to move, will tell you then how hard the eyeball pressure is. So the more you have to push, the harder the pressure and the higher the pressure. So I do a tonal pen, but the downside of that is, the foot plate's really big. If you have like a really ouchy eye, the animal might be moving a little more. You have to use proparacaine. If you have corneal ulcers, you're also like, oh my gosh, where should I put this metal foot plate on the eyeball? Obviously with the condom on there, but, just, it's a little more, you just have to maneuver a little bit more. But traditionally 99.9% of the time we use the tonal vet, but it's also, a few grand more, but it's very handy. And then if you have small animals like pocket pets or birds or reptiles or, guinea pigs or anything like that, they have a lab animal setting for the tonal vet. And so the small little probe is very handy for that. So I like both. When you use the tonal vet, just make sure, because it's suspended by a magnetic field, that you want to make sure you always hold it 90 degrees. We always have our technicians hold it both hands, because these instruments are like $3,000. So I was like, have your support hand. And then when we carry it around, we personally don't like to use the little, there's like a wrist ribbon thing that you can tie to the bottom of the thing, because sometimes when you put it on the table and somebody closes the drawer, we've had it once where it caught and then the instrument dropped. So we actually don't use the wrist loop thing. It whoever who actually puts their hand, let me put it through so it doesn't fall down. It actually was more of a hazard, because we're it's just dangling off, and then we're trying to grab it, and then it's attached to your drawer that's closed, and then your instrument falls to the ground. So that's a little just learning tip. We got rid of all of those. And then they have a little rubber handle that's very handy, because they're very slippery. So those rubber handles, you can get it from your rep, that they help with the anti-slip on your tonal vet. When you carry it around and you're going to the animal, it has to be 90 degrees. If you go like this, the pin will fall out. Okay. So just make sure that your holder has the animal straight 90 degrees. Okay. And then the other thing is, I always rest my hand that's taking the machine. You follow the animal. If you're just free floating in space, you're going to jab the eye with the pin. Okay. So I always kind of position. So it's the same ping, 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 ping. And when you do it, don't cock your hand in space. Okay. So just rest on your holder's hand or rest on the cheek of the animal. Ping, 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 beep, averages. Okay. So it just takes practice. Everybody can do it.
Those are great tips. I will say I have never done a tonometry on a rat, but now it's great to know that they have the setting for that. A question too. So one of the things I do, and I want to make sure that I'm not doing it wrong, is sometimes when I get these dogs that are not really liking this whole procedure of something coming at their eyeball, a lot of these do have a confidence interval. And they'll say oh, it's a 95% confidence. And so what I have told my staff is that if you're getting a reading that's above 95% and you get a nice reading on both sides and we're well within normal, that can be enough, versus trying to get multiple readings on each eye in a dog that's becoming more and more fractious, that maybe we also have to do other things to.
Yeah. So, it is, the 95% interval is quite accurate. So I would just kind of trust it. But if there's any question, because sometimes when you have chronic glaucoma and your eyes this big, you would think the pressures are 99. And there's been rare occasions when chronic glaucoma, it can actually cause atrophy pushing on your ciliary body, that it's so beat down that it actually starts to, the pressures go down. And you're like, how are these pressures 13 with no glaucoma meds but it's been going on for months and months and months. It either gets bigger and bigger and bigger, or it gets just, which happens more rarely, 1 in 10 times, where without glaucoma meds and it's just big, it's been through so much that the ciliary body is like, oh my gosh, I've been so smashed. Then I kind of shrivel and your pressures are low without interventional comfort procedures. So, you just check it. And if it matches and it's low, you can use a different machine. You can check it yourself. I think it's very important because once you diagnose it, you have to treat it, right? So if it's like, oh, and my nurses are great and it's all about learning and teaching. Part of my CEs, I go and I'd be like, this is how you properly hold. If you don't do a proper tear test, like you do your tear test medially, then you're going to get fake dry eye, because in order to do tear testing, you need corneal touch, okay, for corneal stimulation. So if you're like, go do the tear test, and then they're like, the tears are 5 and 5, and you're like, that's weird. This dog came in for blindness, but it doesn't look like dry eye, but they didn't do it properly. So you want to make sure tests are done correctly. So on a side note is like, you always want to have lateral touch, because what do you have that's medial, that's between your cornea and your eyelids? Your third eyelid. So if you put your tear strip right here, then it's like, oh, this doesn't feel so bad. You need the reflex tearing. So then you're going to get fake dry eye. So my point on the eye pressures is that, if you get pressures done and you are not personally doing them yourself as a DVM, and you're like, my tech got like 37. I was like, well, that's glaucoma. You got to treat that. They're like, but it's like, doesn't look like it. I was like, well, what is it going to have to take once the dog, I can't, I can't do it for you. So have you checked them yourself? Because you can't like ignore it, like la 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 la, like that it wasn't. So is it real? If it's real, then you have to treat it, even though it doesn't look like it, right? So make sure it's not the machine, it's not user error, it wasn't like somebody that hasn't done it before. And if you're like, oh, and so I would say 1 out of 5 times when a case doesn't fit for glaucoma or dry eye or something like that, I'm like, you should go and do them yourself and with your own hands and fingers and see what you get. And they're like, oh yeah, it's not 37. I got 17. I was like, okay, so you can mark out glaucoma and then let's move on and see what's going on. Because then it's like not only these like ulcer meds, but you have glaucoma, which is completely different. So I think, the confidence interval is accurate, but you have to read the patient, because if you get high blood pressure and you're like, it's weird, or he doesn't look like he's anaphylaxis, but then like, or his glucose looks 26, but he's not seizing, like, okay, well, is it real or is it not? Like, what is it going to have to take for you to do that? Is it just your machine? Because you're not going to. So same thing with glaucoma or eye pressures. The machine may be 95% accurate, but read the patient. And if you aren't doing the test yourself and it doesn't fit the case, then do them yourself, because what are you going to do with those numbers?
Yeah, no, that's so important. Now, when a veterinarian does identify glaucoma, right, many times it never seems to happen Tuesday at 9 a.m., but some weird off hour. When do they need to be referring to an ER before they can get to an ophthalmologist?
Yeah, so glaucoma is always an ocular emergency. Time is of the essence. Okay, so I have a PowerPoint that I'm willing to share if I can send it to you, and they can get access to the PowerPoint that has like step 1, step 2, step 3 protocol. But you should always offer referral, because there are certain things that we could do in case medical emergency meds don't work or you don't have them. Okay. So we can do a quick way. It's almost like the trach tube, for somebody who can't breathe and none of the meds are working. So we do what's called paracentesis, and we can paracentese the eye to relieve pressure in the eye when you're having a crisis in the eye. But if the owner like has $2 or anything like that, an ophthalmologist can always talk you through it. So, you can always give us a call. We're happy to, coach you through it. Early referral is always key. Collaboration is key to saving vision, because when you come see an ophthalmologist, our first goal is vision. The second one is comfort. Okay. So glaucoma is very vision threatening and it's very, very painful. Okay. So, I would say first thing is offer opto referral, especially if, oftentimes we're like, okay, go grab these meds. Like, you got a glaucoma case, let's go grab these meds. And they're like, oh, we don't have those, which I'm happy to. It's important to have like latanoprost on your shelf at your ER clinic or even a GP clinic, right? Say all the ophthalmologists are in like, Cancun having their opto conference, and you're like the only one in like Billings, Montana, right? Or they can't go to an ophthalmologist. So I would say, it's important to have some basic glaucoma meds to try to bring the pressures down. So those would include like dorzolamide, timolol, latanoprost. They're not that expensive and have a super long shelf life with, preservatives in them that you can have access to. I think that's like the first line of defense. It's kind of like, I have atropine for my situation, right? So that's for opto. You should refer. If not, then usually what we do as a protocol, if you have diagnosed glaucoma, you want to see if it's a lens luxation induced glaucoma. If it's a lens luxation, it's a physical issue where the lens fell to the front of the eye and it's occluding the drain of your eye. So in that situation, you cannot give latanoprost, although it's a really big gun, to lower your eye pressure because it closes your pupil down and can make the glaucoma worse. So in lens luxations, that's like the one main asterisk. If it's not lens luxation induced glaucoma, then you can do the emergency protocol, which is usually dorzolamide, timolol, wait 5 minutes, latanoprost. Wait 5 minutes, dorzolamide, timolol, which comes in a combo. It's actually right here. Combination. It's like a combination medication. Dorzolamide, timolol. Okay, comes in one. Okay, they used to only have it, so they have dorzolamide and they just have timolol separately. But it'll make your life easier if you just do the combo. Dorzolamide, timolol. Okay, so you do dorzolamide, timolol, latanoprost. You do 6 sets. Okay, so 1, 1, 1, 1, 1, 1, 1, 1, 1, 1, 1, 1. So 6 sets, and they're all 5 minutes apart. A learning nugget is your eye only sucks in 1 drop every 5 minutes. You can wait longer, but you can't wait less, okay? Because if you go boom, boom, that previous drop dilutes the previous drop, okay? And that drop pushes the previous drop out onto your face because your eye only sucks in 1 drop every 5 minutes. So make sure that when your meds don't work just in general in life, it's not due to user error. I'm like, oh, that's weird. Your like eye meds like are not doing a good job, like your dry eye meds. And they're like, oh, I just like finish all my drops like in 30 seconds. So I was like, why? And they're like, oh, just because I wanted to get it done. I was like, you have to wait 5 minutes. And you want to always educate your clients why. Otherwise, they're like, oh, I spent all these money on meds and then they're not working. It's because they weren't told. Okay, so that's the emergency protocol. And then you check the eye pressure. Usually this emergency protocol is kind of like the EpiPen for the eye. It'll drop the pressures at least 50% of the time to a favorable pressure. Okay, if not, oftentimes we'll add in what's called methaczolamide. It's an oral carbonic anhydrase inhibitor, and it's a big gun, okay? You cannot use them in kidney or heart patients, okay? Because it messes with your potassium. So then we give it, it's a 5 milligram per kilogram tablet, okay? They come in people form too. The people form is a 50 milligram tablet, where the doggy version compounded is 60 milligrams. So then you pop the mouth and then you check pressures again in like 30 minutes to an hour. Oh, yay, the pressures went from like 52 to like 12. You send them home on like 2 to 3 times a day, dorzolamide, timolol, latanoprost twice a day. If you never needed to resort to the methaczolamide, then you just send them home on the eye drops. They shouldn't ever leave your clinic. Honestly, I always tell my, whenever we do the CEs, they shouldn't leave your clinic with pressures over 25 because, do you send like a blood glucose level of like 37, there's like, here's some dextrose. Hopefully your BG goes up. And we found the problem, but here's your dextrose. Here, you just kind of squirting it in the mouth and hopefully you do good. So you want to make sure it's good. So they shouldn't leave your clinic unless the pressures have become favorable, and then you check it the next day. As a learning soapbox nugget is you always tell the client to give it the morning of before they see you. Okay. Because if you don't tell them, they're like, well, I didn't know if you wanted to give the meds. you should always tell them to, because the pressures are high and they're like, I gave the meds 2 to 3 hours ago and the pressures are back up to 50, then you either increase your meds or you're like, bow, bow. That means the meds aren't working as well. So it's very diagnostic. Just like when I diagnose my like hypertensive retinopathy cases and I start them on amlodipine, it's traditionally, start it once a day. I spell it out. I said, give it in the morning. I do it for a purpose of diagnostic purposes. So when they're rechecked on their blood pressure, and if their blood pressure is 290 still, I'm like, oh, is it because you didn't give the meds this morning? Or is it because I need to go to BID? So you want to spell it. They're like, I didn't know to do it, in the morning. It's because it's just more diagnostic value. If they're like, I gave it this morning 3 hours ago and it's still like 290 or 250 or whatever, guess what I'm going to do? I'm going to go to BID without a blink. Okay. If they're like, oh, say the blood pressure is like 210, they're like, but I didn't give it this morning. I give it at night. That's when I give it. I'm like, oh man, is it just because you didn't give it or not? So I really spell out all my meds as a little soapbox. I say, these meds are antibiotics. These meds are steroids. These meds are for dry eye. These meds should be given in the morning. You got to spell it out because it increases your compliance, helps you better diagnose these patients and just, interpret the testing. So for the eye meds, literally on our labels, we literally will say, one drop right eye 3 times a day for glaucoma. I think compliance goes down when they're like, I'm on these 10 meds, but I don't know what they're for, and when they know like, oh, this was just like a lubricant, that one is, they're all important, but when they call for refills, they're like, it's the white top. I don't know what it's for, but I just have 5 different drops. I think it's important. And then also you always want to write until recheck. My nurses think it's funny when I put like 1 drop, both eyes twice a day, forever for dry eye. So then the clients aren't confused. And they're like, my dog's eye, do I continue these meds? And I'm like, oh, it says on your label forever. So there's no question, because you don't, sometimes they don't, that's a lot of information for them. They're like, oh, what's dry eye? There is no cure. Remember that we talked about that. But if they see it on their meds, they automatically know what's forever. Forever means you need to refill your meds. So you always want to do drops before ointment whenever you tell your clients, because the ointment will prevent penetration of your drops. Okay. So I think it's important. And it's very interesting, I think for GPs and then just in general, like, if you ever there's no point to put instructions on there of like put 2 drops per dose. Okay. There's no point to put 2 drops per dose 3 times a day. The purpose is, these are a lot of them are human medications, right? So they're designed by very smart pharmaceutical companies. Your eye only holds 36 microliters. 32 microliters. Okay. But a drop that comes out of the tip is 32 microliters. Okay. So 36 microliters, 32. Okay. So the point is they count for excess amount. So if you put in 2 drops, you're obviously getting spillage. So your meds are going to go through a lot faster. So just make sure that, there's no medical purpose to get 2 drops in. And then often question we have is, oh my gosh, I got 2 drops in. Is my dog going to be overdosed? It's not like 2 doses of carprofen. It'll just spill onto your face, right? So you don't need to flush it out. It'll be okay. So yes, it is. Your eye only holds 32 microliters. This one has 36. Sorry, I was trying to be like accurate. So it doesn't make sense when they already accounted for overage to do 2 drops in the eye. So that makes sense. And I think it's fascinating. So therefore, you don't need to put 2 drops.
No, and that certainly saves them on some money too, not to overutilize. In situations where you could do an ointment or a drop, do you have a preference?
So I'm a drop person. I think it's just a lot easier to give. I have dry eye myself, and if you ever, I don't know if you've ever put in gel or ointment in your eye, it blurs your vision. So if you have dry eye, it kind of blurs your vision somewhat. So if ointment, I typically like, if you're like, you can't medicate your dog as often, so it stays in hours longer. Ointment's also good when you have entropion and ulcers that you're, softening the hair, right? But if you have a deep ulcer, you don't want to get the mineral oil part of the ointment into your eyeball. That's very dangerous. There's been clients before where it's like, the client's like, oh, I tried to medicate my dog with my ointment in the metal tip. And they were like, oh, try to get it off. And then they harpooned the eyeball and popped the eye, right? So that's not good. It's like, oh, okay, now you have a perforation. So drops are just easier. You come from above and you drop it in the slit, done. So versus like, hey, won't come off. I got it. Like, put my finger in the eye and stuff. And we're like, don't do that. Oh, how about a Q-tip? And we're like, don't do that either, but it won't come off. And, gets greasy around the face and stuff like that. So for the right patient, I will, but oftentimes for ease, cleanliness, lasts longer, I typically like drops, but my business partners, a lot of them like ointments. So it's just kind of preference. And those are my medical reasons for it. But I do use ointment, but if it's like, between they're equivalent for all the factored reasons, I typically like drops.
Yeah, similar to your forever on the label. Whenever I do ointment, I always say, please do not put it onto your finger and then onto their eye. I have had that happen many times.
Yeah, exactly. You have to just spell it out, because what you say, they don't, we know, right? But you have to assume it's like my old Auntie Sue, who's like, doesn't know any better, right? Like, why isn't that okay? So, I always try to spell it out, because, you got to break it down. It's like the average Joe approach. I'm like, this is dry eye. They're like, well, what my dog is like $40,000 from like Belgium. What do you mean he has dry eye? And I was like, well, it's an autoimmune condition. That's the most common cause. What's autoimmune? Like, you got to just break it down. Like, you can't just talk medical always to your clients, because they got to relate. They got to understand, increases compliance. You got to get the message across. So I'm like, okay, do you know what eczema is? And they're like, yeah, I know what eczema is. I'm like, okay, there is no cure for eczema, number one. Okay. And it's like eczema of your eyeball, when you have like immune blepharitis or like dry eye, it's where your body attacks the tear gland and it can't make its own tears. I'm like, oh, okay. So if you, oh, my dog's looking so much better. Is he cured? No. There is no cure for eczema. You stop giving the meds. Just like a person with eczema, his skin's going to look flaky and looks like it's falling off again. Your body's going to stop making tears again. It's going to get all scarred and you can go blind. Don't stop the meds. It says forever. He's like, oh, okay. So you got to just break it down. Like, what is autoimmune? It's where the body attacks that part in your body. What's lupus? What's ALS? There's different variations. My goal is to keep you on the least amount of meds to keep it under control. Not all autoimmune conditions are created equal. Like when I have nodular granulomatous episcleritis, which is also a different version of an autoimmune condition of the eye, typically topicals don't cut it. I need orals plus topicals. So it's very interesting, but you got to explain to them in case, like, is it the diet? Like, no, it's not the diet. It's autoimmune. What's autoimmune? So you got to make sure so they understand their dog's condition and completes compliance, and then they can relatability, understanding, compliance, trust.
Yeah. So important to always ask those questions to make sure that the client is tracking, so you can give the proper level of education that's required for that. We've talked about Schirmer tear tests. We've talked about tonometry. Let's do a little bit about fluorescein stain, which still to this day I cannot spell. But I see people doing it in different ways. I see, well, they'll kind of wipe it. They'll put the whole thing into a 3 cc syringe. They'll put 1 drop. Is there a best? Does it matter?
It's definitely more concentrated if you do the the strip method. Okay. And that's what some of my partners like to do. You have to like get a lot closer and like touch, if you're going to touch, don't touch the cornea. You're going to lift up and touch on the white of the eye. Okay. Because you don't want to have a false imprint by like paper cutting the eye, or even just a light touch. You'll be like, oh, wait, is that like a real ulcer? Is that where I touched with the paper, right? So if you're going to touch the sclera, okay, and then blink, and then it distributes the tear film. So that's important, so you don't get false impressions of maybe that's an ulcer. Is that where I just touched with the tear strip? I like to use the 3cc method because especially in like my brachiocephalic dogs or dogs that are trying to eat me, and I like literally can't get close enough, like, let me stick this in your eye, in your armpit of your eye before you try to bite my hand. So then this one you can airdrop from like, and then the nurse is literally like holding the neck and they're like trying to bite. And then we're like, and then we kind of like look from a distance. So it's a lot more handy that way because your like handle for your like tear strip is a lot closer with the dog that's trying to like literally can smell your hand and says, get away from my face, right? And you don't want stress on some of these animals because you're doing an ulcer to some of these that are deep or some that are like, heaven forbid, is this a desmetocele? And if they're like trying to bite you and it's like a stressful situation and you're trying to like see if he has an ulcer and it's like, oh, he popped his eye, clearly it's fluorescein positive now. So you just want to make it very kumbaya, we like, we try to make it as easygoing as possible. So we do both depending on the situation. I like the 3cc method, but if there's ever any question of like, is that really truly stain positive and it's a nice dog and I'm questioning if it's just because it's too dilute or something like that, then I will use the tear strip. We do switch out the 3cc syringe every day for a new one.
When you do the 3cc saline water, do you fill it up to all 3cc's? How much liquid do you put in?
Yeah, just all to the full 3cc's. Mm-hmm. Yep. And then you kind of drop it in. So, yep.
Okay.
Yeah. Yeah.
Direct versus indirect retinal exam. When should GPs be doing this?
I mean, they should honestly be practicing their opto skills always. We're always inviting GPs to come hang out with us. I love to teach. And I think it's, if you're learning, I always tell my residents, if you're learning 2 things each day to try to improve your skills, I mean, I think it's just super awesome. So you should be looking in every eye, right? Like do the direct because that's the front part of the eye. We use like the direct slit lamp, but you can just do your best with what instruments you have. And then indirect is less commonly used, like whenever we do talk to GPs, but you should always be practicing, right? So the hints of doing that is, grab your lens, okay? And then you want to do like a tapedal reflection. Sometimes you won't, but you don't want to sit there for 5 years because what happens is your pupil just constricts being like, oh, hey, it's bright. So then you're kind of like shooting yourself in the foot. You're like, I don't see anything, but the pupil's this small because you had the light there for like 5 years. Okay. So you need to be efficient, and you'll be efficient if you practice more, right? So it should literally take you within 3 seconds. Light to eye, lens, eyeball. Okay. And then the hint behind this is it's like a constellation. The light, lens, and then the eyeball should all be in the same trajectory. If you're moving your lens, but then your light stays in the same place, you're like, I don't see anything. Okay. So you want to make sure if the eye moves, you move with the eyeball. Okay. It's like a trajectory. So the hint about it is if you want to see more of the tapetum, which is the shiny portion, you drop down lower. Okay. If you want to see more of the non-tapetum, you go higher. Okay. You should always be practicing. You're like, okay, fine, I can see it. What am I looking at? So you should look at 4 main things. It should be the optic nerve. Does it look fluffy? Does it look dark? Okay. Does it look swollen? You should look at the blood vessels. Is there signs of hemorrhage? Are they shriveled up like an avocado tree that's been pulled up and it looks really dead? Or is it like signs of retinal degeneration? Oftentimes retinal vessels are just puny and very thin. Tapetum and non-tapetum, tiny. The tapetum, does it look striated? Does it look like sheet metal from chronic glaucoma or retinal degeneration? Non-tapetum, is it spotty? modeled, if you will, maybe from some fungal disease or some chorioretinitis. Those are the types of things like, oh, Dr. Lee saw 3, retinal hemorrhage spots that were the size of the optic nerve. Dr. Smith, 3 months later, saw the same 3 spots, or is it 8 now? You know what I mean? It's very important to look back there because oftentimes we're like, oh, wow, you have some bleeding back there. We should check your blood pressure. This was not there 6 months ago. We look and it's like, oh my gosh, your blood pressure is very high. And then, the eye is the window to the body. So I can't tell you how many times we look in the body and we're like, oh, this dog had cancer. This cat has kidney disease or thyroid disease. Like, you'd be super, super shocked. Oh, your eye is filled with cloudy fat. What did you eat last night? Like I had a GP, one of my old students called me last week, Brittany, and she's like, oh, look at this case. And I was like, oh, you should ask the owner what they fed them, because the eye, it's like when you have those schnauzers and you spin their blood and it's like this creamy gray color and kind of creamy pink and white creamy color. And I was like, go ask them what they fed last night, if they got into anything. And then I was like, okay. And she's like, oh, and she messaged me later. She's like, they fed him KFC because it was his birthday. And I was like, oh, okay, that's what's going on in his eye, lipemic aqueous. So what you eat will go into your body oftentimes, potentially. So those usually have favorable outcomes. You put them on anti-inflammatories, but that can also induce glaucoma. So you want to like turn it around. It's very scary looking. But, I think you want to always look in the front and the back. You don't know if you don't look. And you don't know it's there if you don't know how to look. So you should always practice. You can come hang out. I do have a Dropbox link that I'll give access to Dr. Lee, and it will take you through how to do a good retinal exam and, just practice. And then if you get good at it, then it's like driving a car. It's not a big deal. The eyeball's not a scary thing. And the other big hint is that even if the dog doesn't come in for eye issues, like the dog is blind or he's like, you should look at normal eyes also, because then you can tell the difference between abnormal and normal. Okay. So that you're like, okay, I've seen enough normals to know that that's not supposed to be there and that looks weird, right? Because we can have what's called subalbinonic funduses, like the blue eye huskies. You look back there, and then I had one that was like, oh my God, I'm sending you a case. This dog's eye is like bleeding everywhere in the back. I think he has a retinal detachment, and it's actually because he didn't have a certain layer in your retina, so you see straight back into his choroid, which is the blood vessels in the back of your eye. So there's different variations of normal. So I think it's very good to encourage to practice. And the eye's so beautiful. It's like a sunshine, like every single eyeball. I'm like, oh. So I encourage you guys to practice, and it's just so wonderful and help you maybe diagnose certain things and look at, assess the health of the body and see what's going on as well.
I love how much you love your specialty. It's awesome.
I love opto. I love what I do. And I'm very I would like to share and teach and whatever. Not everybody can afford a specialist. We totally understand that. That's in every specialty. So just reach out to your local ophthalmologist and they can guide you through, cases on like, hey, should I do ofloxacin versus tobramycin? And then, always try to help your ophthalmologist out, maybe by emailing or texting pictures with a flash, because based on that, the reflection from the iris, we can see if there's like depth to the ulcer, or is there like blood in the anterior chamber, and help you guide you better. But, oh my gosh, that ulcer is way deeper than, and kind of scary looking. It looks like it's melting. We should be on ofloxacin versus just, it's a superficial ulcer. Tobramycin should be enough, or a BNP, for example. So just reach out and, similar questions like, should I use predacetate or, neopolydex? Those are both steroids. I'm sure your local ophthalmologist, it's all about collaboration, and, we're here for you. Your ophthalmologists are there for you. Another big misnomer is like, is it safe to use a topical steroid and a topical NSAID at the same time on the eye? The answer is yes. It's not the stomach. They're not the same receptors. So oftentimes after cataract surgery, we use predacetate and ketorolac at the same time all day long. You obviously want to, have an asterisk to say, hey, call if you see yellow green discharge, or if the dog's holding their eye closed, that could indicate an ulcer, and we'd want to stop it at that point in time. But that's a little thing that we often get asked as well.
Yeah, and you've certainly helped me out. In fact, when you were talking about when those dogs get in and eat a fatty meal, in fact, I'll see if we can share that picture. But the dog came in, the eyes were just totally white. Client wasn't sure if they needed an ophthalmologist or an exorcist. Definitely did look like something right off of a ghost movie. So
Yeah.
definitely you've helped so much. And I think reaching out to specialists and asking for help definitely makes a difference. That's why you're there, is to help guide so many of us through things like eyes.
Yeah, I would say, don't ask, don't get. I'm a big believer of that. Don't ever be embarrassed. Maybe you'll learn something from the experience. We've shared cases before. I think just be prepared to help us out, because we're not mind readers. I'm like, oh, what's the eye pressure? What's the eye pressure? And they're like, oh, I don't know. Like, be prepared that I'm going to ask you, like, what's the pupillary light reflex? Like, what were the tears? What were the pressures? So, I think those tests are quite important. If you're not sure, then just do all three. It's not like 10 tests. Okay. And that'll start as a good baseline. I think, doing a good thorough opto exam is also important. Reaching out for help. Don't be embarrassed. Collaboration's the key. But yeah, just make sure you do all your tests, and so we can talk about the cases together. Often questions we get, like, what if the client can't afford the testing? They have 50 cents, not even $2. Okay, so they can barely afford the GP exam. So what do? We often do, if we'll often. So this is where it's good to be. I'll tell you what we do. So we often write off the tests. Okay. So they're like, oh, I can't afford this. I didn't do this. Or even they come and they're like, well, they already did the blood pressure. I was like, well, this looks like tons and tons of blood. And I need to make sure with my own eyeballs that it really isn't hypertension. It's not writing off blood work. It's a puff on the arm. It's not going to hurt your dog. I'm going to do it. I'm not going to charge you. How about that? And then I can see with my own eye. Just because somebody said it's not cancer or it's not something, I have to put my name to it now. Okay. I think that's just being a good doctor. Does it take extra time? It takes 2 minutes. Okay. I'm like, and they're like, they usually never say no. They're like, oh, it's free. I'm like, yeah, because I'm working you up now. That's why you're here. If it's high blood pressure, my brain and trajectory go a certain way. If it's not, then I got to be like, it's like, I'm going to be, which I would anyways. I'm going to be looking in your gums. I'm going to look at your belly. Like, why are you bleeding in your eyeballs? Okay. Did you get beat up? So, is it trauma? Is it ITP? Like, it's completely different versus hypertension and your blood pressure is like 290. So for the eye pressure tests, if you really, the eye pressure, the stain and the tears, if you really think about the eye pressure is like a puff of air. Okay. I think for GPs, if you work it into your senior like wellness package, add an extra $40 to everybody's every year, and it'll get your machine paid for. Okay. And then after that, like, I think it's the right thing to do, where they're like, we can't afford it. I'm like, this looks like glaucoma. I'm not like, oh, sorry. So I'll be like, we're going to do the eye pressure test. Oh, wow. It is 45. You can invest that money into meds. It's the right thing to do by the animal. And that's something I do feel proud about. And that's how we navigate that. And I do understand not every situation allows that. But I think for those things where we can, we charge where we charge. But I always tell my residents that when somebody needs help, because we charge where we charge appropriately, it allows us the fortitude to help the animals when they need help, and the clients. Not everybody has $1 billion. Not everybody can, barely come and see a specialist. So I feel very proud that we do the right thing when we can. And I think we should all do that if we can. Like, really, how much does an x-ray cost? It's not one of those like old school, like with the hang it up anymore. It's like freaking digital, right? I mean, like, is that really that printer paper? It's like freaking like your iPhone picture, right? So I'm like, what's the right thing to do? And then everybody benefits. It's the right thing to do. Think about your tear strip. That's like 2 pennies. Let's see. the Schirmer tear test strip and then the 3cc. Oh, it's a drop of water. Like, what's the right thing to do? So when I call, like, so when they're like, it's a red eye. I'm like, okay, I'm not a mind reader. Like, can you help me with the client can't afford anything. I was like, try to do your best. That's how we navigate it. And then, that's the honest truth. And then you can always like document owner declined. And then, sometimes we still do it in free, like 99.9% of the time people don't. And I think that's just how we navigate it. You can't be a mind reader and, you just do the best you can.
And what do you wish that every vet knew who might be referring pets to an ophthalmologist? I think you kind of covered this to make sure that they have a few things, but just kind of walk us through like what would be, for most eyes, what would be that minimum number of testing that you want to see before referral?
I mean, obviously, if they, can only afford 2 tests based on your organization's setup, then do the basic testing. So testing can go a long way. Like we gave that scary example. It could be allergies or it could be glaucoma in your eyes, like going to explode, right? So do your basic testing. Try to do all 3 tests if you can. The worst case scenario is you don't find anything. Okay. And it's normal. But if you find something, that's great. And we can go off that. I think if it's ocular emergencies, it's not like, oh, they've had glaucoma for like 3 weeks. Like, oh, like they should have been seen sooner. Early referral. If they don't want to, totally fine. Decline ophthalmology. It's just not as great when it's like, oh, it's been 3 weeks and it's like just this non-responsive, really bad situation. But I think early referral is the key. If they can't, that's totally fine. And, talk to, if you're not getting the results you like this ulcer has been like 3 months and it's not getting anywhere and they only have $2 or there is no ophthalmologist, unless if they go to 2 different states away, then call and ask for advice, send pictures. We're in the new age and collaboration's the key. Change things up a bit. Is it like an infected ulcer? Is it because one of my residents is like, oh, it's a non-healing ulcer. It's 3 months. It's like obvious. I'm going to do a grid procedure. I was like, okay. We always double check. We always but that's how you learn. It's kind of like, I know how to drive. I'm like, oh, okay. You didn't put the emergency parking off. Like, you're not going to know. Right. It's like, okay, let's double check. So I was like, oh, this dog can't blink, right? And just like, oh, okay. Right. So I think it's important that, you do a thorough optho exam, make sure you're treating for the right cause. Because if it can't blink and that's why it has the ulcer, you doing a grid procedure is only going to make it worse. Right. So I think just take it back, start from the basics, do your basic exams, menace, can it properly palpebral? It's not just like, it's an ulcer. We're going to just keep doing meds. Or if you're like doing something, for example, a superficial ulcer, if you have a superficial ulcer and does not heal within 72 hours, because your eye is one of the fastest healing tissues in your body, there's only 3 things on the planet that would cause that. A, it's infected, yellow-green discharge. Second category is you didn't get rid of the cause, okay? Foxtail, ectopic cilia, entropion. You didn't get rid of the cause. It can't blink. It's just like sitting open. Oh yeah, I have an ulcer because I'm just cracking open. Or the third category is an indolent ulcer, SCEDS, boxer ulcer. Those are usually 9.7-year-old dogs or older. So you gosh darn better rule out the first 2 causes before you go and do like a procedure and scratch the dog's eye, right? So if it's not healing, you want to rule out, take it from the top. Just break it down. Eyes are very it's just like, the same type of approach. And, if you're left with the third cause, then of course, then you do the debridement and the grid procedure, but you want to make sure, right? It's like, oh yeah, this dog can't blink. And you want to have good history taking questions. Does your dog sleep with the eyes open? Oh yeah, he just sleeps like this all the time. You're like, oh, well, maybe that's why. So we got to lube it. I had a dog that was sent by a neurologist 2 months ago. And she's like, there's this classic halo, it's non-healing ulcer. And then I was like, okay, let's take a look. And then I was like, your dog can't blink. This is an exposure ulcer. Okay, probably from the healing meningitis that it was battling. So we lubed the tar out of it, and we never had to do the grid procedure. That was not the cause. That was not the cause. You scratching it, causing more fibrosis, and not treating the primary cause, it's just going to potentially happen again. You want to just make sure. So they're like, oh yeah. I was like, oh, I sent your patient, like, we have a plan. We rechecked, ulcer never came back. So, but we're lubing the tar out of it because it's a Frenchie that like sleeps like this. Right. So I was like, okay, you're going to get lubed forever. So I think it's important, just take it a step back, make sure we're not missing anything. Ulcer doesn't mean automatically 1 + 1 = 2. Glaucoma, dry eye, 15 or higher. That's normal. It's not dry eye. Not true. Look at the patient, look at the numbers overall.
You've mentioned the 3 different tests that we commonly do with eyes, but you've also mentioned blood pressure quite a few times. Should that be included in most standard eye workups?
Most of the time we don't do them as a standard workup, but if, you look in the back of the eye because you've been practicing a lot and you love eyeballs, and you go to, like, hey, I'm a thorough from head to toe doctor, right? Doing your annual physicals. I'm always so impressed. I'm like, oh my God, your GP saw this without a slit lamp. They're like, yeah, my vet saw this cataract, or they noticed something like this hyperpigmentation on the iris. I was like, your vet's good. I was like, half of them, like, they're like, oh yeah, I say, and look in the tongue, and they're like, oh yeah, you got 2 eyes and that's it. I was like, your vet saw this and it wasn't a primary. I was like, that's impressive. So, you should do a blood pressure as part of like an annual, on mid to older age dogs. I think that can like pick up Cushing's, like a sign of like, ooh, your blood pressure is high, right? It's not just like eyes. I think that should be part of your thing. Worst case scenario, it's normal, right? Does it take extra time? Sure, but it's a puff of air. So it's not writing off a bunch. I think it's just, that's what they do when they come see us, like you and I, when we go see our doctor, right? So why not for animals? Because that can catch like before your retina's detached and your eyes filled with blood. And it's like, oh, you probably had high blood pressure for a long time now, but it's too late now, right? To bring your vision back. So it's not part of our annual, or what we do, but we definitely do it when we suspect it, but it should be the step before that. So I think, it actually comes way before that. So maybe part of the, and I think it's very justified, right? It's not just about the eyes. It's like, oh, you're whatever, Cushing's, and we could why is your blood pressure so high? Are you overweight, or, what's going on? Or so, do it as part of your screening, but if you do have blood in the eye, they have $2 and they never make it to us. You should have that as one of like the workup things that you want to do. Probably do that before like x-rays if you see eyes, blood within the eye.
No, great advice. And I love how you said, adding in these eye tests into senior wellness. I think that's a great tip for everybody. Kind of wrapping in all of this up, again, summary of what you would recommend to the average GP. I know you talked about practice, adding in all 3 of those tests every time we have an eye. Don't just assume that it's something simple or what it is, but to run the tests. What else? Anything that I'm missing?
Yeah, I think that's just it. It's just try to love what you do and love what you do by getting good at what you do and by practicing. And that's, we're charging for it. So you want to try to do the best possible when you do your screens. And, that it comes as quickly, it's simple as like, oh, I need to get good at checking the eye pressures. And so it's more efficient and faster, just perfecting your trade. I think we're very lucky in the field that we're in, so beautiful, helping animals and stuff like that. And so I'm always trying to learn as well, and like bothering my like mainly cardiologist friends and stuff like that, being anesthesia. And I'm like, oh, the CO2 and, how can we like, do some changes? And I called my GP friend and I was like, oh, what do certain GPs are comfortable with and doing like on the long palate, and what do you typically do if they're like having heat strokes, because we do lots of brachiocephalic animals. I was like, oh, what do you do before your surgeries? And I'm very humble. I'm always like, whatever achieves the ultimate goal within a live patient, his eyes good, his body's good, He can use his eyes that he has. So I just called my GP friend the other day. I was like, oh, Serenia, famotidine 2 days before, because we do an injection right before. I'm like, oh, I'm going to start doing that protocol. I am just always like trying to suck up and learn and trying to be like, I'm never just like going off the knowledge I had from like 15, 20 years ago. And I even from my GP friends, he's like, he sees so many brachycephalic animals. And I'm like, what do you do? And what do you recommend? And it's beautiful what we do. And the eyes are beautiful. So if you guys ever need anything, Dr. Lee has my information. We're here for you.
Yeah, thank you. And for all the listeners and viewers, we will have the links to Dr. Sheahan's notes in the post. If you have any questions or comments, please email us at vetwatch@dvm360. And thank you for watching VetWatch at DVM360, where what you know today protects everybody tomorrow.
Thank you for watching. And then shout out to Dr. Jaggers.